I work at King Faisal Specialist Hospital in Jeddah. Our center serves as a referral center for complicated cases of HIV with resistance and co-infection with hepatitis B and C. I will discuss the issue of optimizing the use of integrase inhibitors in clinical practice with special focus on our region and in Saudi Arabia in particular. Many of the slides have been already discussed by our eminent speakers, but it's always good to reiterate the great benefits of this class of integrase inhibitors. But we'll try to give it some local perspective and see what are the obstacles to using some of the integrases in our clinical practice. So I'll include 3 cases just to demonstrate how we can use the integrases in our HIV-naive patients, and also discuss how to fit the use of this class into our patient's regimen when switching virologically suppressed patients. I've included a case to illustrate many toxicities that can develop during the course of treatment with these drugs and how we can manage patients, particularly with many drug-drug interactions. The issue of 2 versus 3 drugs have been already discussed, so I'm just going to touch on that. And through a case, we'll see what are our options for treating patients with, who are treatment experienced and have multiple class mutations. So starting with the first case, this is a young patient who's MSM and was presented with fever, sore throat, and generalized body rash for a week. He reported a recent sexual partner. His medical history was otherwise normal, and when he presented, he had a quick HIV testing that came back positive. His HIV RNA came back at 500,000 copies per ml. His CD4 count was 180. So like many of our patients who present to clinical practice, he was basically a late presenter. His creatinine was 60. His creatinine clearance was 60. His genotype and HLA B5701 were pending, so we don't have information on that. The patient is willing to start therapy, so what would you start this patient on? Would you put him on a 2-drug-based regimen in the form of dolutegravir and lamivudine versus elvitegravir-based regimen, dolutegravir plus staph FTC, or a darunavir-based regimen, or would you use dolutegravir plus abacavir lamivudine? So going through the international guidelines for starting treatment in naive patients, both the DHHS and International AIDS Society have come a long way in recommending only integrase-based regimen as first line. There are a few differences between both guidelines when discussing the chosen regimen. So with the IAS, they no longer recommend using raltegravir. They identify that due to the complexity of care, the lifestyle of patients, a single tablet regimen is preferred. So they either recommend the use of bictegravir-based or dolutegravir-based regimen. Also, I'm sure you heard about the strategy of rapid starting in many of our patients is gaining popularity. So like our patient, when you don't have any information about genotype testing, the guidelines recommend using a high genetic barrier regimen in the form of bictegravir or dolutegravir. The DHHS guidelines continue to recommend raltegravir. We know that raltegravir used to be given twice a day, but now with the new formulation, it can be given at 1,200 milligrams once a day. So all regimens are given at once a day. However, there is no single tablet combination that contains raltegravir. The other important notice here is that is the lack of a booster. So again, as we discussed a couple of days ago, the management of the elderly patients with HIV, many of these patients are already on polypharmacy. And the guidelines identifies with this, and they recommend not using a booster, given that many of these patients will live longer, they will acquire comorbidities. So the last thing we need is to complicate the regimens with using pharmacoenhancer. Of course, there are many prerequisites that comes to mind when you constructing a regimen in a naive patients, and we have to look at all of these basically in our clinic, in our practice before we pick up a regimen. So you have to make sure you have your data on viral loads, or CD4, kidney function, the risks for osteoporosis, hepatitis B status. As you already heard, many of the 2-drug regimens are not recommended in patients who are co-infected with hepatitis B. For female patients, always have to have a discussion about pregnancy or pregnancy wishes and the use of contraceptives. And of course, I already mentioned that try as much as you can not to give a pharmacological booster. The Saudi guidelines were last updated in 2018. They continue to be balanced. They also recommend other classes like the protease inhibitors and the NNRTIs, but they acknowledge that integrase inhibitors are the first line of drugs. And they don't include bictegravir, but I suspect very soon when they are updated that bictegravir will be included in there. So they continue, I think, like the British guidelines, to recommend other classes in addition to the integrases. This slide has already been discussed by Dr. Pagani, but when we come to our clinical practice in Saudi Arabia, as I said, bictegravir is still not yet available. So for this patient, we have to choose between a dolutegravir versus elvitegravir versus raltegravir based regimen. In our center, those 3 drugs are available. And again, the cons of raltegravir being given twice a day, we don't have the new co-formulation, or sorry, the new dosage formulation of once a day raltegravir, so multiple pills is kind of a disadvantage for giving raltegravir. However, it has a long track record. It's been in practice since 2007. It is our go-to drug when it comes to pregnancy, so that gives it an edge over the other integrases. And the other options that we have in our clinic or our center are both dolutegravir and elvitegravir. Again, the disadvantage of elvitegravir being or containing a pharmacoenhancer. It is a great option for young patients, but for the elderly, I think it might have some issues with drug-drug interactions. Dolutegravir can be given in pregnancy, but it's preferred to be used during the 2nd or 3rd trimester. Okay, and there are tremendous data in the literature for the recommended integrase inhibitors. Some of these clinical trials showed non-inferiority when it comes to comparing the integrase inhibitor to a comparator. Some of them actually showed superiority favoring the integrase inhibitor, specifically dolutegravir, in the single and the flamingo, as well as the ARIA clinical trials. So you have a variety of integrases to pick up, but again, the other factors comes into play when it comes to availability of these drugs. The choice of a 2-drug-based regimen is a hot topic in HIV medicine these days. The Gemini trial has been discussed by Roger extensively, but when it comes to its utility here in Saudi Arabia, this combination is still not available, of course. My personal view on this strategy or regimen are 2 things. First, I think it's a very good option for the elderly patients, where you want to minimize toxicity of many of these drugs, specifically nucleosides. So it could represent a good option for those elderly patients who are on polypharmacy and you'd like to minimize drug-drug interactions. But keep in mind that we always deal with issues of adherence in our patients. Our region remains, when it comes to 90-90-90, among the lowest around the world when it comes to maintaining patients with virological suppressions. There are multiple reasons for that, and of course, and some of them are adherence to therapy. So we're learning about the forgivenessness of this regimen, whether we can use it in those who are not adherent to the regimens. The other issue that we frequently deal with here is the issue of interruption of antiretrovirals due to supply issues. So again, how forgiving this regimen will be will remain to be seen. Okay, so do we still have any place for protease inhibitors or NNRTI in our practice? Again, Dr. Bagani alluded to this. I think in our clinic or in our practice here, we're using PIs less and less. The only clinical indication that I personally use it is in the presence of resistance or failure to first and to second line regimens. Darunavir in particular has a high genetic barrier, and so it shares this trait with dolutegravir. And it is still recommended by the guidelines when you don't have any access to genotyping. That's another issue that we deal with here in Saudi Arabia. Many of the centers are not equipped to have access to genotyping. So darunavir remains a viable option when it comes to first-line therapy without genotyping, and I think that's why the Saudi guidelines continue to recommend PI in that regard. It is particularly good for patients with adherence issues, again, a common problem here, because like any other PIs, they have high genetic barriers. Whenever a patient comes in with detectable virus in the face of PI, what we do is to counsel these patients about the importance of going back into their regimen, and once they go back to darunavir, their virus becomes suppressed very quickly. But there are many issues and toxicities associated with PIs, as you all know. When it comes to endocrine perspective, hyperlipidemia, the GI intolerance is a significant one, as well as recently the cardiovascular risk, increased risk of MI with darunavir in particular. All PIs require boosting, and I've already discussed that before. The NNRTIs, we know that the EACS guidelines now recommend also doravirine to be used as a recommended regimen. Doravirine is combined with TDF, FTC, not with TAF. So it can be an option for patients who have significant weight gain on integrases. That's another hot topic in our HIV medicine these days, and you will hear about this in the afternoon. And in those who are intolerant of integrases. And as you can see, whenever you start someone on a regimen, more than 95% will fall into the preferred regimen where you can use an integrase. But that's the beauty of HIV treatment. There comes the occasional patient in whom you cannot start an integrase. In that case, maybe there is still a place for an NNRTI-based regimen. However, again, many issues with this class, the low genetic barrier, the neuropsychiatric complications. Even in the DRIVE study that compared doravirine to efavirenz, neuropsychiatric complications, although less with doravirine, but continue to happen. Rilpivirine has also to be used in patients with viral load less than 100,000 copies per ml. It cannot be used in patients with advanced AIDS with CD4 less than 200, and it cannot be co-administered with a PPI, so you have to keep this in your mind. So eliminating A because of unavailability and going with the guidelines of not using a booster, we went with both options C and D are correct. HLA-57 is still pending, so it's not recommended to use a bacavir. So you can choose between a PI versus dolutegravir, and we went with dolutegravir TAF FTC. The second case illustrates the toxicities that can develop with the integrases and potential drug interactions. So again, this is a relatively young patient from our clinic who has a long-standing HIV history and is on a regimen that consists of dolutegravir, abacavir, 3TC. He's virologically suppressed for 3 years, However, he's complaining now of tremendous weight gain, and those of you who manage these patients, I'm sure have started to see this complication among our patients. This patient has had a quite significant increase in his weight despite lifestyle modifications, despite his effort to control that with diet. He also has vitamin D deficiency, reflux disease, and osteopenia. He has a higher hemoglobin A1C, and he gets started by his endocrinologist on metformin. The patient wants to change his regimen and demands one pill. So do you agree with him, and what would be the alternative regimen? So in our clinic, we're lucky to have an HIV pharmacist, and we use the Liverpool drug-drug interaction tool or website as a guidance in these patients with polypharmacy. So as you know, there's a potential interaction between dolutegravir and metformin. Dolutegravir increases the area under the care for metformin and can lead to an increased level of this drug, which can potentially have side effects like lactic acidosis. And this is even more augmented with using twice daily dolutegravir. We heard about the chelation interaction in the first talk by Dr. Bagani with the calcium supplements. So answering these two questions, it's not absolutely contraindicated to use dolutegravir in this patient. You just have to space out the calcium supplements. In terms of metformin, with smaller doses, you can continue to give the dolutegravir. However, with the higher doses, it's recommended to switch him. Answering the weight gain issue, that's a very complex issue, and we still don't know how to deal with it. Many patients come to our clinic demanding changing the regimens, but whether changing them to a different regimen like doravirine still remains to be seen. I'm sure these two studies will be discussed extensively in the afternoon, but basically the NAMZAL and ADVANCE study were randomized, multi-center, open-label trials that compared a dolutegravir-based regimen versus efavirenz with a primary endpoint of virological suppression at week 48. But what was noticeable from this clinical trial was a significant weight gain in the dolutegravir arm. The bottom line from these studies, the effect was mainly seen when TAF FTC was combined with dolutegravir, and also in black women. So these were the two risk factors to developing tremendous weight gain, including obesity. Again, whether to switch a patient from an integrase to another class to minimize the weight gain, that we still don't have any answers in that regard. Switching also from a suppressive regimen, many studies in the literature, I'm not going to go over them, demonstrated the efficacy of integrase when someone is switched from a different regimen. The SWORD and the TANGO studies both have been discussed before, and these again remain viable options for patients who are virologically suppressed but are suffering through multiple toxicities. It's important to make sure that you do hepatitis B surface antigen and make sure these patients are not co-infected with hepatitis B, because we've seen cases of clinical flare-up when we switch to dolutegravir 3TC or dolutegravir rilpivirine. Both DHHS and IS recommend rilpivirine dolutegravir as an alternative regimen in those who are virologically suppressed. And we heard the data on the TANGO study. What is noticeable here in terms of weight gain is that in the TANGO study, even after switching to dolutegravir 3TC, patients continue to have issues with the weight gain. So we know now that it's a phenomenon of integrases. It's not only TAF. So that remains to be seen. The last case is a complex patient who was diagnosed in the 90s, started on all different regimens of HIV due to his non-compliance. He's also, he has multiple comorbidities in terms of diabetes, GERD, and hyperlipidemia. Because of his non-adherence, his viral load was always detectable, so he never had any undetectable virus. and it ranged from 5,000 to 22,000 copies per ml with a low nadir CD4. So he was put in different regimens. He was exposed to the old and ugly nucleosides, including the ones that start with D. He received efavirenz, multiple PIs, including the non-boosted PIs, and he was also on raltegravir at some point. I'm not going to go through this, but this is his actual genotype testing, showing that he has triple class resistance. So he has at least 3 TAMs, he has mutations to non-nucleosides, he has, because he was exposed to a non-booster PI, he developed multiple PI regimens. So it's important when you consider a regimen for this patient to go back and refer to the guidelines. And in his case, he had decreased PI susceptibility, except darunavir, for example. So in this case, you have to construct a regimen where you have 2, preferably 3 fully active drugs. And it's recommended that one of these drugs is from a novel class where it has a new mechanism of action. So having this in mind, we put him on dolutegravir, boosted darunavir, and Truvada, or TDF FTC, and his virus became quickly suppressed. Sorry, I don't know if I just put a slide of the Viking trial showing the, can we go back one slide? Efficacy of dolutegravir in patients who have multi-class resistance, including resistance to an integrase inhibitor. During that time when we saw this patient with virological failure, we had financial constraints. We couldn't do the genotype testing, so we could not know whether he developed resistance to an integrase, to raltegravir. But basically, this patient's profile is similar to patients included in the Viking trial. And by placing him on twice daily dolutegravir in addition to boosted darunavir, we were able to suppress his regimen. So to conclude, the integrase inhibitors are first line of choice for naive patients, even here in Saudi Arabia. In the absence of a genotype testing, it's recommended to use an integrase with a high genetic barrier in the form of dolutegravir or bictegravir. Certain 2-drug regimens appear to be as effective as 3-drug regimen. However, we need long-term data to confirm the efficacy of this strategy on our patients. Switching for toxicity can be done smoothly. We have many safe options among integrases. For treatment experience, remember to follow the guidelines, use 2 to 3 fully active drugs in order to attain virological suppression. As more patients are living longer, there's a need for a durable regimen. In my humble opinion, you would need a regimen that consists of a single tablet, that have a high genetic barrier, minimal drug-drug interactions, the lowest possible profile of toxicities in order to achieve durability of treatment in our patients. Thank you.